Alright, so this is a surgical insemination, umbilicus, pubis, thirds. We're going to be going, as always, caudal part of the cranial third and cranial part of the middle third. Through the skin. Delicately through the subcut tissue. Exposing that linear arousal. Lay to the sky, picking up the linear arousal. In and up. And extending that incision with our maxim bones. Just like we do for a spay, cranially or caudally, down to the body wall, turn towards midline, march towards midline, come up. Being nice and delicate. Trying to find our uterus, there it is. We just want to expose both our uterine horns. There they are. And now I'm going to catheterize both our uterine horns. We do it with a 22 gauge blue catheter. Unlike with a vein where you get flashback, you don't get that. So we direct it where there's no vessels, into the middle, and we push off. And we know we're in based on resistance. It should advance really easily. Same thing, finding an area with minimal vessels. Coming to the center, pushing off. Advances really easily. We now grab our semen. We connect our semen very firmly to our catheter. And we slowly inject. Again, the semen, there shouldn't be any resistance. If you're in the wrong place, if you're not in the lumen of the uterine horn, you will get resistance. Other ways of checking is I can feel, I'm kind of pinching off the uterus with my finger and I can feel that fluid coming back and ballooning it. Why do I pinch off? I guess I just want the semen to go forward towards the ovaries before going back. We're injecting slowly. Why? Because we don't want to just squirt it all out, particularly if we're going to make a mistake and we don't want to squirt it outside the uterus. Doing everything slowly, just make sure that if something is not incorrect, we can kind of correct it. It's also to help make sure that the semen doesn't just shoot all the way out the back. We do around half the semen in one horn. Let's pull this catheter out. I do not use any clamps or anything like that. That will just kind of ooze out there, that's fine. Again, forcibly connecting it up to my other side. And just injecting again, nice and slow. This is the way that I was taught. I know that some individuals will do a single catheter in the uterine body. I'm sure that's a very valid method. Just not what I was taught. So I can feel that uterus ballooning and I can feel it hitting my finger back here. So I'm 100% confident that the semen is going where it needs to go. Once we've got all the semen in, now reverse the process. This one goes in, and this one. Why do I not clamp it off? I would just rather have that blood go outside the uterus than inside the lumen. Whether or not that is actually true, I'm not sure. Now closure is just routine. I'm going to use 3O monosin for the linear alba, simple continuous, and then I'll use some 4O on the subcardial intradermis. This is a surgical AI, certainly still done and legal where we are, but it is done less and less. There is an alternative, which is a great thing, which is called a TCI, a transurethral insemination. Certainly we do a lot of those, and certainly as far as success goes, I would say a TCI is absolutely comparable to a surgical, and it's only getting better as we get more skilled at doing it. So I imagine at some stage no one will be doing surgicals, at least in this country. Bella, you wouldn't mind grabbing some big paper can, please? So just for some additional pain relief, what we do is we put in some bupivacaine in the incision, and also place on a bit of a lidocaine patch afterwards. Bella cast and external suture. Frustratingly, I have a knot in my 4.0. Instead of dragging that all the way through.
Do you want 2 or 3?
Let's go 2.0. 2.0 external nylon. Instead of dragging that all the way through the dermis, I will just change plans. All good.